Today's presentation will be talking about obstetric emergency, and this is actually divided into 12 smaller topics that we will have to discuss, because I promise you I will leave no stone unturned. We will be talking about obstetric emergency from all aspects and from A to Z. Now, I don't need anybody to write, because I'll put this presentation published on YouTube so everybody can benefit from it. And if you find that this presentation can really lead to improvement in the way you are handling shocked obstetric patients, or you are handling obstetric emergency in a better way, I would encourage you to share it with colleagues who are obstetricians and gynecologists. First of all, what is an obstetric emergency? An obstetric emergency is a serious, unexpected, dangerous medical situation that requires immediate action. To be obstetric, of course, it has to be at any stage of pregnancy or up to 6 weeks after delivery. By the way, it's better to use the term birth, because women don't deliver, women give birth. So it's a serious, unexpected, dangerous medical situation requiring immediate action at any stage in pregnancy and up to 6 weeks after birth. The causes, of course, will be mainly maternal shock and maternal collapse, because any patient who is shocked or collapsed, this requires immediate action. And here I have to tell you that the causes of maternal shock are not the same as maternal collapse, although all patients who are shocked at some stage, if they are not treated properly, like in this lecture or like in this presentation, they will go into maternal collapse. But we have causes of maternal collapse without going through shock. For example, myocardial infarction, stroke, amniotic fluid embolism, pulmonary, massive pulmonary embolism. All these cases will lead to sudden collapse without going through the stages and the pathophysiology of shock. So we will discuss causes later on in this lecture. However, I want you to add 2 abnormal obstetric events that we will include as a case of emergency requiring immediate action. These are shoulder dystocia and obstructed labor. Both of them are dangerous, both of them are sudden, and they need immediate action. And I will tell you now that many authorities consider shoulder dystocia as the true obstetric emergency, because you have few minutes before you lose a life. But in this today's presentation, we will focus mainly on maternal shock and maternal collapse. We will discuss the definition, physiology, pathophysiology, and types of shock. Definition of shock is deficient tissue perfusion. Deficient tissue perfusion with blood to bring nutrients, to bring oxygen. The deficient tissue perfusion, blood flow per gram tissue, is termed shock. If it occurs at any stage in pregnancy and up to 6 weeks after birth, it is termed an maternal shock. A maternal collapse, on the other hand, is an acute event. Specifically, it has to involve the cardiorespiratory system and or the brain, and it results in a reduced level of conscious, potentially death, at any stage in pregnancy and up to 6 weeks after birth. So as you see, collapse is different from shock. If we talk about shock, the physiology of shock, we said it's deficient tissue perfusion. Perfusion depends on the perfusion triangle, which is the cardiac output on one side, here, and the systemic vascular resistance on the other side, and the base of the triangle has also the blood components, the viscosity of the blood and the volume of blood. The cardiac output is equal to stroke volume times the heart rate. So in order to affect the cardiac output, you can decrease the stroke volume or decrease the heart rate. In order to increase the cardiac output, you can increase the stroke volume or the heart rate. Stroke volume is preload minus the afterload, and it depends largely on the contractility of the heart. So the better contraction of the heart, the better cardiac output you have. Systemic vascular resistance, if it decreases, then, because we have here the cardiac output, is also the difference in pressure between the mean arterial pressure and the central venous pressure in the right atrium. The difference in pressure divided by the systemic vascular resistance is equal to the cardiac output. So this means that systemic vascular resistance, if it decreases, the cardiac output increases, and vice versa. The systemic vascular resistance equation is very important. It is 8 times the length of the blood vessel times the viscosity of blood divided by pi, radius of the blood vessel, to the power 4. The length. What is the length of our blood vessels? Actually, the length of blood vessels is, in a patient or in someone who is 70 kilograms, is equal to 100,000 kilometers approximately. You know, the circumference of Earth is 40,000 kilometers. So this means that the blood has to pump, the heart has to pump blood in double the circumference of Earth, double and a half actually, because it's 100,000. This is not the problem. The problem is that for every 1 kilogram adipose tissue, we have an increase in the length of blood vessels by 700 kilometers. And at the same time, for 1 kilogram of skeletal muscle, you also have an increase in the length of blood vessels by 1,400 kilometers or more. So do you imagine what happens in pregnancy when the adipose tissue increases 8 to 12 kilograms and the uterus increases up to 1.2 kilograms and it takes 10% of the cardiac output? We will see the effect of this later. The second thing that we will talk about is the viscosity. The viscosity is another issue because viscosity, if it decreases, the systemic vascular resistance decreases and so the cardiac output increases. Now this is physics. This is physics. But if you talk perfusion, and perfusion by oxygen specifically, when the viscosity decreases, it means that the RBCs to plasma have decreased. You measure hemoglobin in relation to plasma. So if you increase the plasma, you decrease the viscosity, and this means that you have less hemoglobin per 100 milliliter plasma. This will lead to tissue hypoxia. So what we see in cases of the IC, what we see in cases when we resuscitate patient giving fluids, and not giving blood, this eventually leads to tissue hypoxia. Tissue hypoxia. Yes, you may have maintained the cardiac output. Yes, because physics says that if you decrease the viscosity, you increase the cardiac output. You have maintained the cardiac output, but you have caused tissue ischemia. So that's the viscosity. If we talk about the radius, well, actually one of the very important mechanisms for the body to control the circulation is controlling the radius of the blood vessels. Because radius is not a linear equation. The radius, it's pi to the power 4. So any change, small change in an arteriole radius, if you double the radius of an arteriole, this means that you have decreased the resistance 16 times. But mind you, yes, you decrease the systemic vascular resistance. Yes, you increase the cardiac output. But do you have enough volume to fill up this small dilatation in the blood vessel? This is the question. So radius has to be balanced with volume and with the cardiac output. So it has to be balanced. It's not just a mere equation. You have to balance this with how much volume do you have? Do you have volume to fill up or not? Because if you don't, then you go into a distributive shock where the vessels dilate more than the volume can fill up the blood vessels. So this is the radius of the blood vessel.
All lectures are based on Tocqueville Textbook, your one-stop, postgraduate study source, and decision support platform. You have 14-day free full access trial. Follow the link in the description to start your trial. Remember to hit the subscribe button, and if you find this video useful, please like and share.
So going back to the equation, what if we substitute systemic vascular resistance with the equation down here? Then we have the cardiac output is equal to the difference in pressure between the mean arterial pressure and the central venous pressure in the right atrium times pi radius to the power 4 divided by 8 times length times viscosity. The difference in pressure between the mean arterial pressure and CVP affects the cardiac output, especially in cases of overload. When you have the central venous pressure has increased and so the difference between the mean arterial pressure and the central venous pressure is reduced, and thus the cardiac output is reduced. If this pressure increases between the difference in pressure between the right and left, between the left and right sides of the circulation, this means more driving force and the cardiac output increases. Now we talk about the types of shock. What types of shock do we have? We have types of shock due to the discrepancy between the diameter of the blood vessel and the blood volume present. Either the volume is too low, this is a hypovolemic shock, or the diameter has increased in most of the kilometers of length of blood vessels, and this will lead to the distributive shock or the vasodilator shock. Or on the other hand, we have a very constricted blood vessels. When the blood vessels constrict, this leads to increase in the afterload. There is too much obstruction to the cardiac output as it as the driving force to the blood, and so this is an obstructive shock. Or the heart itself as a pump has failed. Too low stroke volume, too low heart rate will lead to a cardiogenic shock. And we have a very dangerous type of shock, and that is the septic shock. The septic shock has three types of shock together in the same patient at the same time. You have a direct vasodilator effect of cytokines, which leads to the distributive shock. You have edema, which is not local anymore. It's in all tissues because there is disruption in the intercellular junctions, in the endothelial cell junctions. And so fluid leaks into the interstitial space, leaving the blood with hypovolemic shock. At the same time, acidosis and cytokines, especially interleukin 6, lead to direct myocardial depression. So you have also a cardiogenic shock. So in severe sepsis and in septic shock, namely septic shock, you have a distributive shock, you have a hypovolemic shock, and you have a cardiogenic shock. But here I'll stop for a minute because many of obstetricians do not appreciate what is septic shock. We have infection, and then we have another term called sepsis. When I say sepsis, I mean another thing other than infection. And then I have severe sepsis, which is another term. And then I have septic shock, which is a fourth term. So actually I have four terms to use. Infection means there is local edema, redness, hotness in a certain tissue. But when I say sepsis, it means that I have a suspected or confirmed infection with two SIRS criteria. SIRS is the systemic inflammatory response syndrome. So if I have two criteria of the systemic inflammatory response syndrome, this means that I have a sepsis. I don't have infection anymore, it's sepsis. So what are the systemic inflammatory response criteria? They are temperature above 38 degrees centigrade or below 36 degrees centigrade, tachycardia more than 90 beats per minute, tachypnea more than 20 breaths per minute, and leukocytosis more than 12,000 or leukopenia less than 4,000. Any two criteria of this in presence of suspected or confirmed infection means that I have sepsis. And then I have severe sepsis, which is sepsis plus one of three things. Either lactic acidosis with lactic acid above 2 millimoles per liter, or organ dysfunction. And organ dysfunction has a specific criteria. Creatinine more than 1.1 milligram percent or twice the base. Third thing is PTT, INR more than 1.5 in normal. Bilirubin more than 2 milligram percent. Elevated liver enzymes and urine output less than 30 milliliters per hour for 2 consecutive hours. If you have any of these criteria in presence of sepsis, you are not talking about sepsis anymore. We're talking about severe sepsis. And here you have the right to judge the patient as severe sepsis even if these criteria are not present. This is the guideline. So you have the right to say that this patient is severe sepsis and to manage as severe sepsis although you don't have these criteria set in. Septic shock, on the other hand, means presence of one of three things: severe lactic acidosis, which is lactic acid more than 4 millimole per liter, or hypotension. When hypotension sets in, In a case of infection, this means you are in septic shock, just hypotension. Hypotension is systolic blood pressure less than 90 millimeters mercury, or drops 40 millimeters mercury than a previous reading, or mean arterial blood pressure less than 65 millimeters mercury. A mean arterial pressure is systolic plus diastolic again. Now you have three figures divided by 3. So systolic plus diastolic over 3. This is the mean arterial blood pressure. If it's less than 65 millimeters mercury, this means you are in septic shock. Or again, the third is clinical judgment. So by clinical judgment, you can say this patient is in septic shock and treat her as septic shock without all these criteria present, just by clinical judgment. So this is what we mean when we say infection, sepsis, severe sepsis, or septic shock. That's why when someone admits a patient, calls me and tells me, I have admitted septic abortion, then I am like, yes. Okay, complete the sentence. Septic abortion in sepsis, or in severe sepsis, or in septic shock, or is just the infection and I don't have any criteria of systemic inflammatory response. You have to give me a complete diagnosis. We as obstetricians do not use these terms in a correct way. Sometimes it's just by impression. And by the way, I don't mind impression, because clinical judgment is your impression about the case. If you say severe sepsis, fine. Then treat as severe sepsis. But you have to include this in your diagnosis. This is sepsis, severe sepsis, septic shock, and when you inform or when you document, you have to document this in patient notes. So now that these terms are clear, we go back to pathophysiology. Pathophysiology is how the body responds to a state of shock, to a state of deficient tissue perfusion. First, an event happens, a shock eliciting event. We will use this term a lot. This is followed by pallor. Pallor is not a sign of deficient tissue perfusion. Pallor is not secondary to hypotension. Pallor is simply reduced hematocrit. So because of the shock event that is happening, vasodilatation or loss of blood or sepsis or whatever, there is a reduction in the hematocrit, and this is reflected as pallor. So pallor is not a compensatory mechanism by the body. Pallor is just a presence of mucous membranes are pale because there is reduced hematocrit. The second thing that happens is that the heart will start, or the body will start to try to increase the cardiac output. The body will try to increase the stroke volume and to increase the heart rate. And then it will try to reduce the radius of the blood vessels, trying to balance the radius of the blood vessel with the blood component present. And this will lead to increase in the systemic vascular resistance. As I said, the radius of the blood vessel is balanced with the volume present. So in cases of hypovolemic shock, the radius will try to constrict in order to accommodate the blood present and to provide drive to the circulation. In cases of vasodilated vessels, like in distributive shock, it will try to constrict. In cases of sepsis, it will try to constrict. Always it's trying to constrict, because usually the cardiovascular element in shock is that the vessels need to accommodate a smaller volume. So the radius will be balanced, as I said, with the cardiac output to maintain the cardiac output. In all conditions, the blood pressure here will be on the low side. It will not be hypotension. Hypotension does not occur at this stage of compensation. Hypotension occurs as a decompensation, because when there is hypotension, this is not a compensation. This is failure of compensation. So the blood dropped. The blood pressure dropped from the physiological, dropped from the normal values. So the blood pressure starts to be on the low side in order to be permissive, to allow the cardiac output, to allow the flow of blood. So it will be low, but it will not be below 90. If it's below 90, this is hypotension. Okay? Some authorities say that hypotension in pregnancy below 80, but I will stick to 90 millimeters mercury. And then we'll try to increase the respiration a little bit, because perfusion at the end of the day is oxygen. So we'll try to increase oxygen content of blood by increasing the respiratory rate, by increasing the depth of respiration. The lung capacity, inspiratory capacity, will try to increase it. If all this fails, then the body goes to a preferential circulation, which means that we will try to reduce the length of the blood vessels in order to reduce the cardiac work. The length of the blood vessels is reduced by closing or vasoconstricting the vessels of the largest organ in the body, which is the skin. So the skin is now pale and cold. It was pale only. Now it is pale and cold. Pale and cold means that the blood is shifted to the vital internal organs. And then if this fails, the blood pressure goes to be on the hypotensive side. It drops below 90 millimeters mercury. So hypotension is actually a sign of decompensation. You have left the compensation, the compensatory phase is now, you are beyond the compensatory phase, you are now in a decompensation. There is decompensation, and so hypotension occurs. After hypotension occurs, there will be multi-organ dysfunction and multi-organ failure, and eventually death of the patient. So these are the compensatory mechanisms. First, we increase the cardiac output. We work on the radius of the blood vessels in order to maintain the cardiac output. And then we work on the respiration by tachypnea and increasing the inspiratory capacity. And then if this fails, we go to preferential circulation, and the skin becomes pale and cold. And then we go into hypotension, which is very late in shock, and then the multi-organ dysfunction and death. However, in septic shock, the events are a little bit, sequence of events is a little bit different, because in septic shock, the first thing which happens is edema, which is leakage of fluid. And leakage of fluid outside leads to organ dysfunction. And the vasodilatation by the cytokines will lead to early hypotension. So organ dysfunction, which occurs very late in a shock state, in septic shock it occurs early. And the cardiac output, which is trying to increase, is resisted by the fact that there is acidosis, and acidosis will lead to more leakage, by the way. Even albumin will leak outside the blood vessels, and if albumin leaks outside the blood vessels, this means that we are in severe state, because albumin is responsible for the oncotic pressure, responsible to bring the fluids back into the blood vessel. So actually what happened is albumin leaked outside, taking with it fluids, and so the vasodilatation is more severe. Now I am in severe hypotension, and because of the interleukins, cytokines, and the acidosis, there is depression of the myocardium, and so the cardiogenic element is early in shock. So the major differences between septic shock and other types of shock is that in septic shock I have early organ dysfunction, I have hypotension may occur early, and this, by the way, early, but still it is a sign of septic shock. So what I'm saying is septic shock occurs early. Okay, there is severe acidosis from the start, so very shortly after the systemic inflammatory response we get acidosis and we get myocardial depression. So this is the difference between types of shock which are straightforward, like the distributive, the hypovolemic, the vasoconstrictive, and between the septic shock. Septic shock, everything occurs very fast and occurs early.